All right, we're going to get started. Some things around here on my screen. So good morning and welcome to the UW-Madison Division of Extension WISE Wisconsin Virtual Learning Series. Thank you all for joining us today. As most of you know, I'm Sarah. I will be doing the introduction this morning, but I am in Madison for some meetings. So I'm going to pop off, and Amanda Kostman is going to be here to support our speaker today. And Alicia, I think, is going to do some background support as well and help monitor chat. Just to go over a few announcements before we get started. During today's presentation, please keep your mic muted unless there's an opportunity for engagement or questions. Feel free to post questions in the chat as we go, and we'll make sure to come back to those questions at the end of the session, or if it's appropriate. I think for today, there's a lot of content, so we'll revisit questions at the end. And if you're afraid you'll forget, jot it down or pop it in the chat, and Amanda and Alicia will make sure to revisit those at the end. As a reminder, there is closed captioning for those of you that would like to use it or need it. You can find that at the bottom of your screen. So just click to get that little banner up, and you click on the show captions, the little CC icon, and that will enable closed captioning for your screen. Our session is being recorded today, and it will be posted to our YouTube channel, which I've been sending in all of the emails. Our first 2 weeks are already posted, and last week's session on grandparenting should be posted possibly by the end of today, but for sure by the end of this week if you want to revisit those. We will be posting a link in the chat to the evaluation for today's session, and we appreciate all the feedback that you can provide us. So please take a moment to fill it out. We really appreciate all of your feedback so that we can best meet your needs in the future. I will also send out some updated slides from today, as well as some links to resources, and I'll make sure to put that evaluation link in there again. The evaluation link is the same for each session, so if you weren't able to evaluate a different session, feel free to do that as well with that link. So thank you again for joining us. Today's session is on facts, myths, and screenings for cancer. It's presented by Meredith Turany from the UW Cancer Carbone Center, and I'll hand it off to her to formally introduce herself. Thank you, Meredith.
Thank you, Sarah. I'm just going to go ahead and pull up my screen here and let me know when everybody can see this. All right. Can everybody see my title screen there? All right, excellent. And thank you again for welcoming me to the WISE Wisconsin. I'm a community outreach specialist, and I work at UW Carbone Cancer Center. My role is working in the Division of Community Outreach and Engagement. What we are at the Cancer Center is a National Cancer Institute. So we are the only comprehensive cancer center in the state of Wisconsin. This is actually our 50th anniversary this year. And we are the first cancer research center founded by a university in the United States. So it's pretty fun. I get to do a lot of really awesome work in the community, which is what I love. I spent the better part of my work in the clinic, working in cardiology and working directly with patients. And now I get to go out and work in the community and give all these fun talks and meet with people like yourself. So thank you for welcoming me today. We are going to talk a bit about facts, myths, and screening for cancer. Like Sarah said, if you have any questions, I welcome you to put them in the chat as they come up or jot them down. If I can't answer a question today, I will be happy to take it back to my team. I work with some amazingly bright and wonderful doctors and physicians and other medical staff. So I can also provide my email when we're done today. And if you have any questions, just please feel free to email me directly. So I'm going to start here by giving a little background of the UW Carbone Cancer Center and the Division of Extension. We have had a community partnership for a number of years. You can see up there on the screen that photo. That's our community outreach and engagement team, which includes myself in the back row, along with 3 other outreach specialists. And then our front row is our director and our physician program leader. So we are focused on working in all 72 counties of Wisconsin. That includes rural, tribal, urban, underserved areas. We are very committed to working with areas that have less access to medical facilities, because we know that those populations are at much higher risk for developing cancer, as well as needing more intervention more frequently. We also are really hoping to just have you understand the burden of the cancer incidence in Wisconsin today. And one of our goals is always to work on people that have, excuse me, let me go back here. Just missed that slide. We're just really concerned with working with communities that have a disproportionate burden. And then lastly, we are always thinking about ways that we can connect people like yourself and other communities to the research that's happening at the university. We have a number of things like clinical trials and innovative studies ongoing. So anytime we have new information, we're hoping to be able to share it in this kind of capacity. All right, so we'll go over to that slide 3. Today for our goals, my work, or rather my goal for you today, is to recognize the burden of cancer in Wisconsin. So we're going to talk a little bit about that to start with. I'm also hoping to have you gain a better understanding of some facts and also some myths surrounding cancer. That includes not only the diagnosis, but some treatments and some outcomes. And then I'm also going to provide you with information on certain screenings that are recommended specifically by the U.S. Preventative Services Task Force. And then, as I said, if you have any questions or anything you'd like to ask me, I'd love to hear from you about any cancer-related issues in your community. All right, so this is just a fun picture of something that we get to do working in the outreach division. This is members of our community outreach team from the UW Carbone, who are now hosting this biannual radio show at WORT, which is WRT 89.9 FM. It's a community radio station here in Madison. And this is sort of, the reason I'm leading with this is because typically when we do these radio shows, we get lots of questions, and many of those questions are just myths surrounding cancer. So people want to know all these crazy ideas of what they heard and what their neighbor told them, and somebody they know that had cancer and this happened. So this is one of the ways that we love to stump those myths, is having people call in and ask these questions. So hopefully today we can kind of go through some of these things. But I am going to start by leading off with giving you this information that cancer is actually the leading cause of death in Wisconsin. And we do know that the most common cancers are lung, breast, prostate, and colorectal cancer. And actually, of those 4, really lung, breast, and colon are the 3 that we are recommending screening for. So we're going to talk about that later today. And we know that Wisconsin also has about 87 people every day who will be told that they have cancer, which is an astonishingly high number of people on a daily basis. So what we want to talk about too is just ways that we can reduce our risk, because many cancers have risk factors that we can eliminate or we can reduce entirely. And this infographic right here is actually something that is on the Wisconsin Cancer Collaborative page. And the Wisconsin Cancer Collaborative is actually a statewide coalition of organizations that are working to reduce the cancer burden in the state. So the Wisconsin Cancer Collaborative, it's on the handout that we sent to you. You can go to this website and pull up these infographics like this. We have resources for all 72 counties in Wisconsin, so you can go in and just pinpoint exactly your county and the cancer statistics. And there's also information about attending things like our regional and our annual summits, which just provide you with an opportunity to learn more about what's going on in the state with our cancer plan. And so the next slide, I'm going to spend a little bit more time here talking about this. This is actually a 2023 most updated profile of cancer in Wisconsin. And you'll notice that there are 2 different colors here on these bar graphs. The teal color represents the number of cases overall, and the blue is going to represent the number of deaths. So we know that these 5 most common cancers on the left are female breast cancer, prostate cancer, lung, colorectal, and melanoma. And we can see at the top there that female breast cancer by far and wide is the most commonly diagnosed. But if you noticed in contrast there, it has far fewer people that are actually dying from breast cancer, which tells me that our innovation and our treatments are getting better and that people are living longer with breast cancer and maybe even living without breast cancer if it's been caught at an early stage. And prostate cancer, kind of similar. High number of people in the state that actually have the diagnosis, but far fewer that are actually dying from it. And prostate cancer is one of those that if we catch it early, it can be almost curable. And then in contrast with that, we have lung cancer, which is a high number of residents, but then almost 3,000 people as compared to 4,000 being diagnosed are actually dying from lung cancer. So much harder to treat, much less curable. And typically lung cancer is one of those that's found in a late stage. So the outcomes are not as good. Colorectal also pretty high, pretty good numbers in terms of survival rates. And then melanoma, same thing. A fair number of residents have melanoma, but very few have actually had fatal outcomes. And then we know over on the right-hand side that we have a number of risk factors, and most of these risk factors are actually ones that we can control. So our smoking, our drinking, our obesity rate. And when we talk about obesity, we're talking about morbid obesity. We are not talking about being overweight. In fact, being morbidly obese or being very underweight, neither is actually good for cancer outcomes. So you want to be somewhere in the middle. So people are always happy to hear that, you know, it's okay to be just a little bit on the heavier side. It actually is good for cancer outcomes. And then adult inactivity. So if you're not staying regularly active and getting exercise, that can impact. You will see the drinking rate is relatively high as compared to the United States. So this is comparing Wisconsin overall with the United States. And we actually have pretty good numbers. We measure lower on many of these, like inactivity, smoking, but with drinking, it's very, very high. And we are going to talk a little bit about alcohol and cancer today, which is really a hot topic here lately. And then down here at the bottom, we talk a little bit about screening and prevention. We have pretty good, higher than average rates of screening for mammos. We have about the nation's average for cervical screening. We have a little bit higher on the colorectal side. And then we also have much higher on the HPV vaccination initiation. And that's your first dose of the HPV vaccine. So all right, we're going to move on here to some cancer basics and some facts. And I should mention there that I put that Wisconsin cancer profile there that you might have seen that at the bottom. That was actually a link that gets you directly to that page. And that can also be found on the Wisconsin Cancer Collaborative site. Okay, so cancer basics and facts. We know that about 300,000 people in Wisconsin are living with a cancer diagnosis. And that could be, you know, stage 1 through stage 4. So very early stage through advanced. And that is shocking and alarming and scary when you think about how many people actually have cancer. It actually rounds out to about a third of the people in the United States that are also living with cancer. And because we see this alarming number, and we know that everybody on this call is probably affected by cancer in some capacity. They know somebody, they've had it themselves, maybe their children have cancer, maybe their grandchildren. We know that this is just something scary. And so really what we are committed to do, especially in our outreach and engagement team, is give you the tools and the information that you can hopefully prevent cancer. And cancer starts basically by overcrowding normal cells. So we know that our body is made up of millions and trillions of cells. And the normal cellular process is for cells to die off when they become old or when they become abnormal. And what happens with cancer is we have these old cells and we have these abnormal cells, and they grow and they proliferate and they continue to overcrowd these normal cells. And so you'll see on that image to the right, that's just an image of a cancer cell kind of invading this normal tissue. And when we talk about cancer, we also talk about the different types of cancer. And so I like to think of, we want to break the cancer down into our blood cancers and then also our tumor cancers. So we know that cancer of the blood is leukemia, which affects the blood and the bone marrow, We have lymphoma, which actually affects our lymph system, and our lymph system is responsible for removing excess fluid and also helping with immunity. And then we also have something called myeloma, and this is actually cancer of our plasma cells. And our plasma actually helps to produce antibodies which fight infection. So if you know anybody that's ever had myeloma, they are very, very highly susceptible to getting tiny little infections that most people's bodies can fight off. So all blood cancers are malignant. And what that means is everything you see here is actually considered cancer. So if it's malignant, it has the capacity to spread and circulate systemically, which means it is technically metastatic. Now, tumor cancers are slightly different. So you can have a tumor on your body that's benign, which means there's no cancer. And if you do have a malignant cancer, that would be something like lung, prostate, breast, or colon cancer. And if a cancer is malignant, it actually does have the capacity to metastasize. Metastasis actually occurs when you have a cancer that starts in a certain area or certain organ, and then that same cellular makeup spreads to a different part of your body. So if you had lung cancer and that lung cancer cell then spreads to your bones or your brain or another organ, we call that metastatic cancer. The outcome for metastatic cancer is not as great. It's harder to treat. It's oftentimes you're chasing this cancer to try to fight it and try to treat it. And so it typically is not a great outcome for metastatic cancer. And I do see a couple things in the chat here. Okay.
It just had to do with the internet connection. So
Okay, wonderful. Just wanted to make sure. All right, so I'm going to go ahead and move on. This is going to be your opportunity here. Speaking of the chat, if you want to just chime in or type in the chat here, we're going to talk about some true and false questions here. So we're going to start debunking some of these myths. So do cell phones cause cancer? And feel free to just type this in the chat or turn your mic off and let me know what you think. I'll give you a minute here. And I don't see anybody typing, so oh, I got one answer. Okay. All right, well, no. Many no's here. All right, that's correct. Cell phones do not cause cancer. So according to the best studies that we've completed so far, cancer is actually just caused by genetic mutations. And we know that cell phones emit a certain frequency of energy, but it does not damage the genes and is not proven to cause cancer. So what about herbal products? Can herbal products cure cancer?
no.
All right. Awesome. Couple more no's here. Looks like everybody, nobody believes in the herbal products. Correct. They cannot cure cancer. So we know that there are things out there called alternative or complementary medications. We call that CAM for acronym. And complementary and alternative medications and therapies can include things like herbs or teas or acupuncture, any sort of thing like that that's not considered like a Western medicine treatment. And we know that some of those treatments actually can help people with side effects from cancer treatment, but nothing has ever been proven to actually treat cancer. All right, is cancer contagious? This is a tough one. Got a bunch of no's here. All right. So it's a little bit of a trick question. Cancer is not actually contagious. It doesn't spread from one person to another. The only time that cancer could potentially spread is in the case of an organ or a tissue transplant. So a person who receives an organ or a tissue from a donor who had cancer does have an increased incidence of potentially having developing cancer from this transplant. So I should say that's kind of like a in the middle answer. It's not really false, but we'll talk a little bit about that later with viruses too for HPV. Oops, I gave you the answer to this one. Do antiperspirants cause cancer? And I'll just kind of keep us moving along here anyway. So there is no evidence linked to chemicals that are in antiperspirants or deodorants, which changes any specifically breast tissue. A lot of people were worried about that. If you've ever had a mammogram, oftentimes they tell you not to wear your antiperspirant or deodorant. That has nothing to do with cancer. That just has to do with blocking the lymph ducts in your body. So, and then if someone in my family has cancer, will I get it too? This is also a little bit of a challenging one. Okay, I've got a maybe and a no and a maybe. Good. I like this. You guys are on the right wavelength here. So not necessarily. So about 90 to 95% of cancers happen because of these mutations and these genes that change. And during a person's lifetime, most people are just exposed to environmental factors like tobacco smoke or radiation. Those typically are the reasons you get cancer. So there's like a 5 to 10% chance of getting cancer in a hereditary situation. All right, we will talk a little bit about genetic mutations in a couple slides later here, but these are just some more cancer myths, common myths, and I'm not going to go through all of these, but I just wanted to pull these up on the screen, specifically because these can actually be found at the National Cancer Institute's website. So if you have a question about anything we're talking about today, they have a really excellent webpage just designated to myths about cancer. So we will just move on here to treatments. Okay, so when I describe treating cancer to patients and to the population that we talk to here at the outreach department, I like to think of it as preparing your garden for the spring. And so as Sarah noted, we had such a lovely spring teaser of a day yesterday, and now we're back to like freezing cold temperatures. But I personally love to garden, and it gets me excited and makes me ready to just say goodbye to winter. And at the beginning of every season, we have to get our gardens ready. And so the first thing we do is we have to weed anything that's in our garden. We got to get rid of all the old debris, and that's what we would consider to be a surgery when we're trying to remove cancer from our body. And surgery is the oldest and the most common treatment for most cancers. However, we know that in our garden, if surgery or removing the weeds will help, we still need to get rid of things that are under the surface, and we still might have debris that's under the dirt. And so we would maybe use a weed killer or some type of spray. And in that capacity, we would consider that to be chemotherapy. And whenever there are two treatments that we use together, we call that adjuvant systemic treatment. So somebody that has surgery might also receive chemotherapy or vice versa. And then last thing we're going to do in our garden after removing our weeds and killing our weeds is we're going to make sure that there isn't anything else left that we can, before we plant all of our flowers or our vegetables for the season. And so we're going to burn anything that's left, burn the weeds, and we're going to consider that to be our radiation. Radiation is this form of energy that is a particle or an electromagnetic wave. And what it's designed to do is target the cancer to shrink it and to reduce the size and eventually get rid of it. And so some radiation is kind of harmful, but our radiation is really becoming more, the treatments are becoming better, and they are becoming more targeted at really curing and getting cancer and not affecting the rest of the healthy tissue in the body. Okay, before moving on here, I'm just gonna take a quick sip. We're gonna go right into cancer screening and prevention. And as I said earlier, I'm really gonna focus today on the cancers that we can effectively and recommended for screening. And so we're really gonna talk today about breast cancer, colorectal, lung cancer, and cervical. And you might realize that I'm leaving a couple of cancers off, such as skin and prostate, and we'll talk about that at the end. Those are actually newer cancers that have less the guidelines have changed, if you will. So we'll talk about that today. All right, so we're going to start with breast cancer. And you'll see up on the left-hand side, this is just a picture of normal breast tissue, which shows the ducts, the lobules, the lymph nodes, and all the areas where we would actually be able to see any cellular changes for breast cancer. So the disease does progress by developing an abnormal tissue, either in the lymph node or the breast. And most people that have breast cancer, if the cancer is developed or the stage is further down, they might feel a lump or a mass or any change to their breast. Now, there are many people that have they can't feel anything in their breast, and they still find a very small cellular amount of cancer. So the diagnosis for breast cancer is going to be a mammogram. Just in the past year, the U.S. Preventative Services Task Force has now recommended mammograms starting for anyone at age 40. And this is a change because this used to be at the recommendation of your physician only. The other way to diagnose is also through a breast ultrasound and also doing a biopsy. So that's removing tissue from the breast or taking an ultrasound imaging to see if there's changes as well. And we know for prevention, what's very important for breast cancer is to understand if you have a genetic risk of breast cancer. And probably people on the call here today have, heard of what's called the BRCA1 and 2 gene. And this is a gene that actually increases your risk of cancer by about 7 out of 10 chances and getting cancer before you're age 80. So if you do have family members that have the BRCA gene, you do want to get genetic testing to see if you also have this, because it can increase not just your risk for breast cancer, but also cervical and ovarian cancer. And we know that prevention across the board for cancer is going to be diet, exercise, limiting alcohol, and also quitting tobacco. And then in terms of our risk for breast cancer, our family history can be risky again if we have genetic changes or genetic mutations rather. But most women who get breast cancer don't have a family member who has actually had breast cancer. Women who have had early periods or early menstruation before age 12 and who have gone through menopause after age 55 have had a longer lifetime exposure to estrogen and progesterone, which puts them at risk as well. And then lastly, people who have had radiation to their chest, or anyone who has taken DES, and that's a medication that was given in the 40s through about the late 70s to reduce the risk of miscarriage. Those people are also at an increased risk for breast cancer. All right, and if you have any questions, please feel free to put them in the chat so we can talk about them after. So we're going to move on to colorectal cancer. And again, you'll see there on the left, just kind of some visual image or infographic of what the colon looks like and the different layers in your colon. And we know that 7 people every day find out that they have colorectal cancer in Wisconsin. And it is actually the second most common cancer after lung cancer. And 90% of the people that have this diagnosis are over age 50. And we know that about 1/4 of Wisconsin adults between 50 and 75 are actually getting their colorectal cancer screenings on the regular as recommended. So the screening protocol is different based on if you have ever had any polyps removed or if you ever have had the diagnosis of colorectal cancer. And the disease actually starts as this growth on the inner lining of your colon or your rectum. And polyps are what are typically found. So if you've had a colonoscopy and you've had polyps removed, the chances are these could have been cancerous or precancerous polyps. And typically, if you've had that, you will have a less time between your next colorectal cancer screening. So if they don't find polyps, they usually give you a longer period of time before you have to get screened again. And symptoms of colorectal cancer really vary, but most people just notice a change in their bowels or any sort of rectal bleeding or discomfort. I want to just put this blanket statement out there that any bleeding is not normal. So for many, many years, people thought, okay, a little bit of bleeding, no big deal. maybe it's a hemorrhoid, any bleeding is not normal. So if you have any changes at all in your bowels or anything unusual going on, you do need to address that with your doctor. And there are so many different ways now that we can actually diagnose colorectal cancer. The gold standard is still going to be the colonoscopy. I'd be lying if I said I wouldn't recommend everybody get a colonoscopy that qualifies for one, because it's really the only way where we can actually remove the polyps if you do have any. It gives us the full scale of information about your colon. But if you have any reservations to doing a colonoscopy and you qualify for the Cologuard, you can, in the comfort of your home, go ahead and do this mail-in kit and send it back, and we can evaluate the Cologuard to see if there's any possibility of risk of cancer. Fit kits are the same way. So the Cologuard has this unique way of also testing the DNA in our stool to tell us if you have an increased risk of polyps. One thing that's really important to recommend or talk about too is this early detection. We are now in this stage where we have what's called early onset colorectal cancer, where people in their 20s and 30s are getting diagnosed with like stage 3, stage 4 colorectal cancer. You've probably heard about it lots in the news. I feel like every other day there's a celebrity getting diagnosed with colorectal cancer that's quite young. So very concerning to think about, but also knowing that we can detect this early, your chances of survival are incredibly high, especially if we detect it at a low stage. Bowel disease or genetics can also put you at risk for this, but ultimately it's lifestyle. So alcohol, tobacco, sedentary lifestyle, diet, those are all hugely important and play a massive role in colorectal cancer development. All right, so we're going to move on to the third screening, which is going to be our lung cancer. Lung cancer is a hard, this is a challenging one because a lot of people feel like, well, lung cancer is probably going to happen to me if I was a smoker, or it might happen to me if I was a long-term smoker. And typically the advice the advice that the U.S. Preventive Services Task Force is recommending is if you are somebody that smoked for 20 years, and that's 1 pack a day, or you smoked up to 2 packs a day for 10 years, you are at an increased risk of developing lung cancer. There are many other ways that you could develop lung cancer too, which include things like radon or asbestos exposure or secondhand smoke. But ultimately, those are going to be like the main things that we're going to be looking for here in terms of screening if you were a smoker. So lung cancer does start as a tumor in the lung nodules that typically changes in size. And unfortunately in lung cancer, there are not very many symptoms in the early stages, which is why it's so important to have this low dose CT scan if you know that you are a 20-pack beer smoker. Many people that have lung cancer will also have a worsening cough. They might cough up blood. They might have this ongoing pneumonia or bronchitis that they can't shake. And again, this low dose computed tomography is what's going to check to see if there's a change in the nodules, a nodule that gets bigger or nodules that develop, and that can actually be something we'd biopsy to see if you have cancer. So we know that quitting tobacco 100% is going to be our best way to prevent, and also reducing our risk of exposure to toxins. Wisconsin is actually has very high radon levels in many parts of the state. So many people on the call here might have the privilege of having a radon mitigator in their home where they can detect the levels. This is an excellent tool to have so that you know you're reducing your risk of radon exposure. If you are a current smoker, quit smoking. That's the end of it right there. And if you are around somebody that smokes, maybe just don't be around them, because secondhand smoke can also cause lung cancer as well. So. All right, so last up here, we're going to talk a little bit about cervical cancer. We know that cervical cancer screening is something that is also recommended by the U.S. Preventative Services Task Force. Our cervix connects the uterus to our vagina, and this is the area where the cells, we can find cells that are changed that could potentially be abnormal and indicate pre-cancer. So we know that these cells can become abnormal over time. I'm guessing that people on this call that have a cervix have had many pap tests or HPV tests to determine if they have the human papillomavirus, which is actually what can cause about 90% of cervical cancer. So these precancerous cells are things that we keep an eye on. They're also things that we remove, you know, by taking them out surgically or by, you know, in the presence of a physician. And cervical cancer is also asymptomatic in the early stages. So really, it's important to get that HPV or PAP screening to determine if you're at high risk for developing. People that have cervical cancer symptomatically might also experience extreme vaginal bleeding, pelvic pain with intercourse, abdominal pain. These are all, again, things that you would need to address with your doctor. And typically the diagnosis is going to be a pap test every 3 years. And that's going to be based, again, on the incidence of HPV or the amount of change in the precancerous cells. And then if you don't get a pap test, you can also just get an HPV blood test to check for the human papillomavirus. And we'll talk about this a little bit more here in the next couple slides, but the HPV vaccination is really going to be something that can prevent the spread of cervical cancer, as well as 6 other types of cancer that are also very common in men. So head, neck, oral cancers, those primarily in males, are going to be the HPV, human papillomavirus. So we know sexual history and HPV infection can increase our risk for cervical cancer, as well as having any sort of immune deficiency problems. All right. And so kind of just to circle back here with HPV, it is the most common STI in the US, and you can have what's called a low risk HPV infection or a high risk HPV infection. And the higher risk HPV is going to actually put us at a greater risk of developing cancer. So we know that all sexually active people are typically infected with HPV within the first months, the first years of becoming sexually active. We know that the HPV virus is made up of more than 200 different viruses, and this is spread basically through skin-to-skin contact. And most people that have HPV have no symptoms, so that means they're spreading it from partner to partner or person to person. And we know that the protection is going to be this HPV vaccination, as well as using condoms. So in order for us to prevent the spread, number one, we want to get an HPV vaccine if we qualify for that. Number two, we want to use protection if we know that the person that we are with has HPV infection. And then also we want to screen again with the pap test or the HPV blood test. And the 6 different types of cancer that can be caused by HPV include cervical, oral, penile, vulva, anal, and vaginal cancer. And as I said, the cervical cancer is responsible for about 90%. 90% of cervical cancer cases are caused by HPV. And also 2% of high risk in men. So of those 6 cancers, for people that don't have a cervix, those are the typical breakdown there. All right, I'm just going to pause here just to see some questions. All right, so Donna asked a great question, and I'm going to get to that next here. So good timing, Donna. Okay, let me know if you can see that there on the screen. Okay, so this is going to be our breakdown of our chart. So we'll start at the top with our cancers, go into the screenings and the ages, and then ways that we can prevent. So we talked a bit about breast cancer, mammography starting at age 40. You can also have this MRI or ultrasound, but mammography is going to be the most recommended, as well as a clinical breast exam. So we are no longer, U.S. Preventive Task Force is no longer recommending to do self breast examinations. That being said, if you find any sort of change by happenstance doing a self breast exam, you should address that. But typically it's not going to be recommended. Clinical breast exams are those that are provided by your doctor. when you see your OB or your family practice doctor. And a cervical cancer, we know that the Pap tests and the HPV tests are going to be our screening tools. And for people with the cervix, starting at age 21 through age 65. And again, this is going to be every 5 years if you test with a Pap, or every 3 years if you just do a Pap and no HPV blood test. And HPV vaccinations can actually start as early as age 9. They can also go up through age 26. It is recommended if you have not been sexually active at the age of 26, up until you start, you could actually have the HPV vaccination as well. What HPV vaccination does is it actually prevents you from new infection. So if you already have a low risk HPV infection, it will prevent you from getting a high risk from another exposure. It's not going to eliminate what you already have. I just want to make that clear because people do ask that question a lot. For colorectal, we know that colonoscopies we want to have starting at age 45. I personally think we're going to see a change in that in the next couple of years with the early onset colorectal cancer. I wouldn't be surprised if it gets bumped down to like 35 or 40. So keep your eyes open for that. Maybe it'll happen. Regular colonoscopy and stool tests are based on your doctor's recommendations and also your symptoms. So typically these are going to be, I believe, every 5 to 10 years based on if they find any polyps in your colonoscopy. And then a stool test, so a Cologuard or a FIT kit, those will probably be less often simply because the colonoscopy is going to give us more information about any tissue changes. And then lung cancer, we know a computed tomography scan, low-dose CT is going to be our screening tool, starting at age 50 up till age 80 for people that are current or former smokers, that 20-pack year, and then reducing our environmental exposure and quitting tobacco. And then at the bottom here, I talked about the skin and the prostate cancer. Most recently, last April, the U.S. Preventative Service Task Force has indicated there's insufficient evidence to support these regular skin exams to check for skin cancer. So if you see something on your body, a change in a mole, or a mole that's maybe hasn't healed or is bleeding, that would be a reason for you to go address that with your doctor. Reducing your sun exposure, of course, wearing SPF of at least 50, those are all ways we can prevent skin cancer. And then lastly, prostate cancer. This is actually going to be a varied recommendation for a prostate-specific antigen test, typically starting at age 45. And having any risks or symptoms of prostate cancer would be something you address with your doctor. Prostate cancer is, we have some physicians, some scientists at the university that are doing some really cool work with biomarker testing. So they're able to test elements of our blood to see if you are at increased risk for developing prostate cancer. Kind of different than this PSA test. So I'm excited to see what comes of that in the next few years. But prostate cancer is a big one because there are lots of people being diagnosed with it, high level people being diagnosed in our state. So, all right, Donna, can I share this with the group? Okay, Donna says that her husband had prostate cancer at age 50. Should my son have prostate testing earlier than the recommended age of 45? That's a great question. One thing with prostate cancer, does your husband have, if he had the BRCA gene, that would put him at increased risk for having, that might have caused his prostate cancer. So that would be good to know if he has that gene. And if he does, your son would want to get tested for genetic testing, okay? And I would say that in terms of prostate, if he has symptoms like frequent urination, the urge to go to the bathroom very often, things like that, those would be concerns to address with the doctor, where they might decide to have him do a prostate test to check for cancer. So yeah, I would say probably yes. That's a really good thing to keep in mind.
What is the gene again?
Oh, it's the BRCA gene. BRCA is what a lot of people call it. And if your husband is a carrier, your son could possibly be a carrier too, which could put him at risk. So.
Thank you.
Yeah, you're welcome. Great question. And the next couple slides here, I just want to give you some information about some programs that we have in the state of Wisconsin. So we have this awesome program called the Wisconsin Well Woman. And this helps people who have little or no health insurance get screening for breast and cervical cancers specifically. So this program actually pays for a breast exam, it pays for diagnostic testing, it will even pay for an HPV test to check for if you're at risk for cervical cancer, mammograms. It even actually pays for multiple sclerosis testing for people that are high risk, as well as a pap test and pelvic exam. You don't have to pay any copay or deductible or premium. And you do kind of have to fit into this little window of opportunity. So if you're between the ages of 45 to 65, if you don't have health insurance, your monthly income falls into one of these levels based on the size of your family. This is an excellent program. I've put the information up here, and I believe I shared it with Sarah and Amanda as well. So we'll make sure you get that website if you're interested in learning more. And the Well Woman of Wisconsin program does have a contact for every county, I believe, in the state. So if you go onto their website, you should be able to just plug in your county and find out who your representative is that could teach you more. And then if you are interested in lung cancer resources, we have at University of Wisconsin, we have the Quit line, which is this 1-800-QUIT-NOW. This is free phone support. They offer free samples of things like nicotine gum, lozenges, patches. They have free counseling and smoking cessation classes. And then they also will get you involved in the UW clinical trials. This is an opportunity where you can work with researchers to learn about effective treatments for stopping smoking and also lung cancer. And this is something that I believe I put at the end of our slide. And if not, if you have questions about that, please email me because I have a direct contact through the clinical trials as well we can connect you with. Okay, we're almost done here, and I appreciate you guys, your focus and attention. So I just wanted to put up here on the slide some red flag symptoms. These are not exclusive to cancer. So really just keep in mind that any of these symptoms you see are reasons for you to visit your provider. So it doesn't mean you have cancer or any other chronic disease, but they are not anything that you'd want to sit on and wait for a month or two. So just kind of take a look at that there. And if it's anything that applies to you, please make sure to seek out medical attention. And as I talked about at the beginning, rather, alcohol and cancer is really kind of a hot topic these days. We know that cancers, many different cancers are associated with drinking alcohol. And unfortunately, when we surveyed people, this was in a study done by the University of Wisconsin, there were about 39% of the people surveyed were unaware of their alcohol and cancer risk. And really about 4% of all cancers in 2020 were because of alcohol. So we know that alcohol produces this thing in our body called acetaldehyde, which is basically the breakdown of alcohol. And this can actually damage our DNA. And when it damages our DNA, it can cause these changes to our liver, and it can increase our risk specifically to head and neck and esophageal cancers, as well as colorectal. It causes lots of cellular damage, and it's more of a long-term issue, not necessarily a short-term issue. So we really know now that no alcohol is good, not even just a small amount. That being said, drink in moderation, and just remember that if you are consuming alcohol, you have an increased risk of cancer. Maybe say no to alcohol more often, or saying yes to it infrequently is the way to go for you. And ultimately, just to wrap up here, we want to talk about basic prevention. So seeing our provider every year, eating well, increasing our activity, and reducing or quitting tobacco, maintaining a healthy weight. Like I said, somewhere in the middle is the happy, healthy zone. So we don't want to be on either end of the spectrum. And then limiting or avoiding our alcohol, using sun protection, and then also just getting our HPV and also our hepatitis B vaccination. And in terms of your risk reduction, these are just some little tidbits that you can pass on to your loved ones, people in your family, your friends, choosing healthy decisions, asking your provider and really being an advocate for your personal health journey. This is very important because sometimes we have about, 5 to 10 minutes with our physician on an annual basis. So if you have questions, my chart your doctor, request another visit, make sure that your questions are being answered. Keep your peers and your family informed where they can reduce their risk. And then also just knowing your family history and understanding your cancer risk. And that is the end of my presentation. So I am happy to take other questions.
Well, thank you, Meredith, for sharing your time and knowledge with us. This was a great presentation. I know I learned a lot. I am going to put a link to our evaluation in the chat at this time, but I also want to invite anybody else, and thank you all for showing up, to ask any questions. You can either unmute yourself and ask the question or put them in the chat.
I have, excuse me, I have a question. Excuse me. Recently, I just caught a tidbit of the news, and they were saying we're doing well in treating cancer, except for, I believe it was uterine cancer.
Mm.
Is that true? Or did I mention right?
Oh my gosh. I will have to actually look that up and get back to you, Donna, or maybe get back to Sarah and Amanda and have them relay the information. I know that uterine cancer is, I believe it's harder since we don't have a screening for uterine cancer or ovarian cancer. We just have the cervical cancer screening, right? So we don't have an actual tool to be able to go and check that or to screen it effectively. So that's a harder one to answer, I think. In
Thank
terms
you.
of treating it, though, I don't know. I would have to get back to you with that information. And I see another question here. Oh, maybe it's just a thank you. Does anyone else have any other questions they want to ask or put in the chat?
This is Karen. I just recently heard someone say that a loved one has cancer and please don't give them chocolate.
Oh, interesting.
And I just didn't even address it. I just thought, okay, if that's, I don't know where that came from.
Yeah. I should have put that on my cancer myths because, sugar is one of the big myths that makes cancer grow. And, you shouldn't eat
Yeah.
sugar because it makes the cancer worse, which is false.
Yeah.
I've never heard chocolate specifically.
And my mouth kind of went, because she likes chocolate and it's, a comfort for her. And it's like, why would we not give chocolate? But
in hearing some of the advice of the physicians that I work with as well, who have talked about people going through cancer treatment, the big question is the diet and the nutrition and making sure you get adequate food in, because oftentimes you don't have an appetite or you're not hungry or you're losing weight. And most every doctor I've talked to and listened to in presentation has said, comfort food is whatever tastes good, whatever they're going to eat is what you should be consuming. That being said, trying to get the wide array of vegetables and nutrients and minerals. So I've never heard anything bad about chocolate though. So I would debunk that.
yeah, okay, all right.
Well, if you don't have any more questions and you think you might have some at a later time, I'm going to put my email here in the chat. So please feel free to email me, and I put my full name in here. And I'm happy to take any other questions, or if you want, like I said, email me directly. One thing that we also like to do in the outreach department is provide information at any upcoming events, tabling. So if you do have anything that's coming up in your area that you think the Carbone Cancer Center might be a good place for us to do some community outreach, please feel free to connect with your extension staff. They can go ahead and pass that on to me as well. We'd be happy. We go on the road all the time. So.
Meredith, there is another question in the chat.
Oh, sure.
If radiation to the chest is a factor for breast cancer, does this mean chest x-rays and screenings for pneumonia, etc., should be limited for the chest x-rays?
That's a good question. Radiation to the chest, sorry, when I mentioned the radiation exposure, I was referring to people that actually have been treated for lymphoma in the past. So it's a different type of radiation. Yes, though, x-rays are still going to give you a small amount, and I can't speak to the amount of radiation you're getting from an x-ray, but I believe that the screening for pneumonia is probably, doctors are usually keeping track of that, the number of times you've been exposed to x-rays and radiation. So I guess I would recommend talking to your physician or talking to your provider about that if you're concerned, and seeing if there's alternative ways to maybe check for that, like in the form of an MRI, which has no radiation.
Well, hearing no more questions, if they do come in, we'll answer those as they come in. I want to again thank you, Meredith, for coming and sharing that knowledge and your time with us this morning. Thank everybody who came in here. We hope you enjoyed this. Again, I'm going to put the evaluation. I really would like to encourage you guys. Your opinions and your perspectives are very important to us. So please fill out that evaluation. Also, all the websites that were addressed and the new slides will be coming out. You'll receive an email from Sarah, so that will be there as well. And I want to make sure that everybody has a fantastic day and wish you guys all the best. But please, if you have any more, let's go ahead and put those in the chat, or you can unmute yourselves and ask those questions. In fact, I see something in the chat. I've heard thyroid cancer is on the rise. Is that correct?
Sandra, I'm gonna have to look that one up as well. I'm not sure if it's on the rise. But you have my email, and I will do my best to get back to the team on that.
Thank you, Meredith.
Yeah, thank you guys. All right. Well, I appreciate everybody's time today, and I hope you all enjoy this sunny day wherever you are. It's a little cold though still, so maybe we'll get spring weather again soon. So thank you all.
Thank you. Have a wonderful day, everybody.
Yeah, you too. Bye-bye.
Bye.